Okay, let's go ahead and get started. Looks like the numbers of people streaming in are slowing down a bit. Thank you for joining us. Good morning, good afternoon, good evening. I'm Jessica Farringer. I'm the Director of Data for Impact. This month, you are joining us for our third webinar in a series on integration in evaluation. And we are joined by Palladium's Antony Ojwang and Jonathan Friedman, who will explore the integration of machine learning models with electronic medical records, as was achieved through the Kenya Health Management Information Systems project. Just in case you are unfamiliar with Data for Impact, here's a little bit on what we do. Our main result areas are to generate strong evidence for program and policy decision-making, to build individual and organizational capacity for evaluation, and to enhance the use of data for global health programs and policies. So as I mentioned, this is the third in a Data for Impact series focused on integration. Today, obviously, is on integration of machine learning, and February and March's webinars were recorded and are available on our website if you would like to access those. February was on development of a tool to assess the gender competency of family planning providers. And then March, I had two presentations on data integration under the Demographic and Health Survey Program. Then in May, we have a rescheduled webinar that is looking at disease surveillance using a One Health approach in Burkina Faso. And then June is in development, and we'll be announcing that soon. So now I will introduce our presenters, and I'll note too that we will handle questions at the end of the presentation. Please put your questions in the Q&A function, and we will have time at the end for questions, so do not fret. So Antony Ojwang is Palladium's EMR architect and technical lead under the KenyaEMR project, where he provides overall technical leadership for the architecture and implementation of KenyaEMR and mHealth products. He has a master's in science in applied computing or health informatics, and a bachelor's in science and information sciences, information technology. And then Jonathan Friedman is a senior technical advisor for data science at Palladium, and he oversees machine learning initiatives across global health projects covering predictive analytics, optimization, and anomaly detection. He previously led data science projects for the U.S. Internal Revenue Service and the Department of Defense, and has a BA in International Affairs and an MA in International Economics. With that, I will turn things over to the presenters. Let me change my slides for you. And if you haven't introduced yourself in the chat, please do so at this point. It helps us to understand our audience and potentially direct some descriptions differently based on who we have. Okay, and there you go.
Okay, thank you so much, Jessica. Thank you for the invitation. Thank you everyone for joining today and sharing some time with us. My name is Jonathan Friedman. As Jessica mentioned, I'm a data scientist with Palladium. I'll kick off the presentation, and then about halfway through, we'll switch over to Antony. I'll start just with a bit of background on the project and provide some context for the slides to come. So the Kenya Health Management Information Systems project, which is funded by CDC, has developed and deployed an electronic medical record system called KenyaEMR across more than 1,000 health facilities in Kenya that provide HIV/AIDS services. Over recent years, the project has also developed an information system to centralize the data from these health facilities and store them in a national data warehouse. It has developed a variety of analytic tools that sit on top of the national data warehouse in order to help the government of Kenya monitor progress towards epidemic control. A little while ago, using the data that's stored on HIV testing results that's stored in the National Data Warehouse, we began to explore whether we can use a machine learning approach to better predict for clients coming to a facility for the first time, the risk or probability that they would test positive for HIV/AIDS. And so we'll get into in the subsequent slides why we looked at this and how we looked at this and what were the results. I'm going to walk through the process of building the machine learning model. In a sense, building the machine learning model is something that's been done has been done with a little more frequency in the global development space. And I'll switch over to Antony, who led the process of integrating the machine learning model as a real-time decision support tool in KenyaEMR, which is something that has fewer precedents, fewer examples in our space. You could go to the next slide, Jessica. There. So just a bit more context on this project and why we looked at this topic. So to help reach the 95 targets, Kenya invests in HIV testing services to increase the share of people living with HIV that know their HIV status. However, resources for testing services, including provision of test kits and staff, are facing increasing pressure. So it's essential that Kenya allocates testing resources using analytic insights in order to increase testing yields or the share of HIV tests that are positive. When we started this work, there were about 1.9 million HIV testing records that had been collected in the National Data Warehouse, of which 73,800 or so were positive, or just below 4%, or a 4% positivity rate of 4% yield. So if Kenya could better target patients and locations with testing resources, we could ideally find more HIV positive patients while conducting fewer tests overall. So to generate these insights, the KeHMIS project used supervised machine learning, we'll talk a bit more about that, to predict patient level positivity, considering factors along 3 dimensions, the who, where, and the when. So the first is the who to test. And for this, we use looking at which demographic variables are associated with positivity. The where to test, or the locational attributes that describe the area, the geographic area in which patients are coming to clinics to get tested. And then finally, the when to test, including times of the year, even around associated with holidays, and times even during the week when test results consistently show higher positivity rates. Next slide, please. So this is a depiction of the current testing workflow at a facility that provides HIV testing services. So currently, health facilities apply eligibility screening questions to determine which patients are eligible for HIV testing. So looking at the top left, if we have 20 patients, 20 clients that come to a clinic, through the eligibility screening questions, hypothetically, let's say healthcare workers will determine that 8 of the 20 are not eligible for testing, including 1 you'll see colored in red, who is actually positive, and that 12 of the 20 are eligible for testing. So of the 12 that are eligible, they will be tested. And in this hypothetical scenario, 2 are positive and 10 are negative, yielding a 16% positivity rate. So, and as I mentioned on the previous slide, this is hypothetical. The actual positivity rate observed is closer to 4%. But here you can see a hypothetical flow in which some patients are, a large share of HIV negative patients are tested, and a small number, but some positive patients are screened out through the eligibility screening process and are not being tested. If you could go to the next slide. So what we're trying to do here is to add an additional layer of machine learning enabled screening. Sorry, thanks. Is add another layer of machine learning enabled screening on top of the current human screening. So we're not trying to replace the current screening process. Right now, we're trying to supplement it by adding another layer of risk scoring. So what we're trying to do is essentially 2 objectives. One is to see if among the patients who are already passing, in a sense, the eligibility screening and are being tested, is there a way that we can identify some patients using machine learning who really are very low risk and could possibly be screened out using the machine learning model. The second objective, in some sense, the more important objective for CDC and the government of Kenya is to try to identify patients who are currently being screened out through the eligibility screening process and therefore right now are not being tested. Can we identify if any of those patients are in fact high risk and should be tested? And so what we're trying to do, there's those two objectives which we're balancing in this project, to identify patients who currently are being tested who are sufficiently low risk that perhaps they could bypass testing. More importantly, to identify patients who currently are being screened out who are in fact high risk and should be tested. If we move to the next slide, the next couple of slides, I'll just walk through the actual process of building the machine learning model. So first, the data sources that we had available to train the model. So the most important data source was the data that had been that was available in the national data warehouse that was put together, built over years, and connected to the more than 1,000 health facilities by the KenyaEMR project. So in the HTS, the HIV testing services module in the national data warehouse, we had information on clients' demographic data, things like their age at testing, their sex, their marital status, information about whether they were tested, and they had been tested previously, whether they were coming to get tested alone or as part of a couple, the testing strategy by which they were connected to a facility. And then we also had the HIV client testing data. We had their actual test results, which was a critical part of this process. So that we actually had the test results that we could learn patterns between the demographic data and the test results. Finally, the third piece of information we had from the national data warehouse was the name of the facility where each patient was tested, as well as the geospatial coordinates. So we had the latitude and longitude for each facility where a patient was tested. So that third bullet allowed us to then pull in additional data sources. So once we knew where a patient was tested with the latitude and longitude, we were able to then bring in information that described a bit the demographics and some of the social behavioral norms in that area. So the way we did this was, starting with the latitude and longitude for each facility, we first created something essentially what's called an isochrone, or an area around a facility that would reflect the population that would most likely seek care at that facility. So the actual definition of an isochrone is a geographic area that one can travel across in the same amount of time. So for example, for a given facility, a 30-minute walking isochrone would describe the area in which someone could walk to the facility within 30 minutes. And so that's how we defined an area around a facility, using those isochrones, the travel times from where patients live to a facility. So once we had that geographic area, that isochrone or catchment area around each facility, we then pulled in some open data sets that were in a geospatial format, so that we could then map the data in those geospatial data sets to the catchment areas around each facility. So some of the main data sets that we used, we got information about the local demographic distributions. We got this data primarily from Facebook and from Rollpop, which makes this data publicly available. Another key source of data for us was HIV and behavioral metrics. So things like prevalence of condom use, prevalence of having a partner who is away from home for an extended period of time, and various other metrics, which we can talk more about, that are derived from survey data and other data by the Institute of Health Metrics and Evaluation. So we pulled in this data from IHME. And then the third bucket of data that we brought in was from the United Nations and other sources that describe some of the infrastructure and economic profiles of the areas around each facility. So this was the data set that we developed in order to start training machine learning models. If we go to the next slide, so here's an example. The model that we have developed is actually trained on data across the country. But here we're just giving an example for one county, the Homa Bay County, which is in the southwest, the Lake Victoria region of Kenya. So in Homa Bay, we started with about 44,000 patient records, patient test results, I should say, HIV test results. In terms of the split between male and female, was roughly a 50-50 split in the data set. Most of the patients, about 85%, were between the ages of 15 and 45 years old. So just a small minority of patients under 15 or over 45. In order to train the model, for those of you who are familiar with the machine learning process, this will be familiar to you. For others, I'm not going to get into too much detail now, but happy to discuss this further. But we followed a process called a train, validate and test. So that involves taking the 44,000 patient test results that we had. We split it into 3 subsets, a 60% subset, a 20% subset, and a 20% subset. What we did is we take the 60% of the data, which is called the training data, and this is where we actually apply our machine learning models to learn the patterns in the data, to learn what are the demographic or the locational or the temporal variables in our data set that are actually associated with positive or negative test results. So which are the variables that we've collected that actually will help us to predict whether a patient will test positive or not. So we'll use that 60% of the data to train the model to learn the patterns. We'll then take that 20% subset, which we call the validation set, which is data that has the same variables, but we haven't looked at the results. So we'll take the models that we've developed, we'll make predictions for that 20% of the validation set. We'll then compare our predictions to the actual test results, and we'll see which model did a relatively good or relatively bad job of predicting the actual outcomes. At this stage, we'll then take the model that had the best predictive power, and we'll make predictions on the final 20%, that last test subset, which we've never looked at before in our model training process. And that'll give us a sense of essentially how will the model do when it sees data for the first time, when it sees patients that it's never looked at before. And this is the best way for us to get a sense of how well will the model generalize and work in an actual facility setting when it's looking at client information that it's never seen before. So in the machine learning process, there's not one machine learning model that we try. There's different categories of machine learning models. And so we, in this project, we trained or fit logistic regression models, random forest models, XGBoost models, and artificial neural networks. Those are the 4 categories. In reality, for each of these, we tried many different iterations with different hyperparameters, which is a term that may make sense to some of you. But these are the 4 categories of models that we trained. And for our evaluation metric, we use something called the area under the precision recall curve. So just a couple notes on the area under the precision recall curve. On the next slide, we're gonna walk through the precision recall curve that we achieved for the best performing model. Precision is sometimes also called positive predictive value, and that means of all the times that we predict a positive test result, how often are we correct? So if we predict 100 positive cases and 30 of them turn out to be positive, our precision or positive predictive value is 0.3 or 30%. Recall is also called sensitivity, and that is of all the actual positive tests in our data set, how many did we correctly predict would be positive? One note on the precision recall curve is that the way in which we evaluate, so the area under the precision recall curve will be a number between 0 and 1. And what's key about this, understanding this curve, is the reference point. So a model that essentially performs at random will have an area under the precision recall curve that's equivalent to the overall positivity rate in our data set. So the positivity rate in Homa Bay was about 5%. If our model had no predictive power at all, we would expect to see an area under the precision recall curve of about 0.05 or 5%. I only point this out because for those of you familiar with machine learning, there is another type of curve that is often used to evaluate models called a raw curve. For the raw curve, the reference point is 0.5 or 50%. So when you see a raw curve, a random model or a model with no predictive power would achieve an area under the curve of 0.5 or 50%. For a precision recall curve, the reference point is not 50%, but the overall positivity rate. So on the next slide, we'll walk through the results that we achieved in Homa Bay. So here you can see in the best performing model that we achieved had an area under the precision recall curve of 0.54. And this is compared to an overall positivity rate of 0.05. So we were pretty very happy with these results. We want to see an area under the curve that's substantially higher than the positivity rate. And here we achieved an area under the curve that was about 10 or 11 times the overall positivity rate. So it did show a good amount of predictive power. What we're seeing here on the graph in the left is a nice way to visualize precision and recall. So what we've done here on the x-axis is you see the label % of patients tested. So what we've done from left to right is we've sorted the patients in our test set we've made predictions on the 20% subset of patients, and we've sorted them from the highest risk score, the highest predicted probability of testing positive, to the lowest. So all the way on the right are the patients that have the highest probability of testing positive. All the way on the right, as we move from left to right, the probability of testing positive, the risk score generated by our model decreases. Then you'll see two curves depicted here. The red curve is recall, or the percent of positives that are correctly flagged. So if we go all the way to the right-hand side at 100, this is when we're testing all patients. If we test all patients, we'll see the red curve is at 100. We test every patient, we'll find every positive. That's essentially what the red curve is showing all the way at the 100 point. The blue curve is precision. So the blue curve is the positivity rate, essentially. And here, if the model had no predictive power, what we would see would be a totally flat, a horizontal blue line. So what we want to see is exactly what we see, is a curvature in the line. What this curvature tells us is that this model is doing a good job of being able to distinguish the patients likely to test positive versus those unlikely to test positive. So just as an example, if we look at the number 5 on the x-axis, percent of patients tested, if we go up to see where the blue curve crosses 5 on the x-axis, it's a bit above the 50 on the y-axis. So what this is telling us is that if we make predictions, generate risk scores for all our patients, and then sort them from highest risk to lowest risk, if we focus just on those 5% of patients with the highest risk scores, more than half of them tested positive. And then if you look at the red line, we also see it's about the same point, around 0.5, that if we focus just on those 5% of patients with the highest risk score, we'll actually flag about half of all the patients that tested positive. So this is showing a really strong ability to separate out the patients likely to test positive from those unlikely to test positive. We can identify the 1/20th of the patients who are actually tested, and that 1/20th of the patients that we can separate out we can identify had a very high positivity rate, represented most of the positive tests. So we can take the patients who were tested, separate them into a 95% and a 5% subset, and be able to consolidate much of the positive results in the 5%. So this is an encouraging result from our perspective. This shows that our model is able to identify and separate which patients are likely to test positive versus which patients are likely not to test positive. One other thing I just want to point out is that in order to select the best performing model, we use the precision recall metrics for the model overall. We did also do some additional diagnostics to see whether the model performed better for different subsets of patients. In particular, we looked at precision recall, the area under the precision recall curve, separately by sex and by different age groups, particularly over and under 15. What we wanted to look for was whether the model was performing better or was producing more accurate results for one sex versus another sex, or for one age group versus another age group. What we found was the performance was actually pretty even. We were struggling a bit with performance for patients under 15, in particular because we had very few examples. There were very few examples in our data set of patients under 15 who in fact tested positive. And so we did do some additional work to try to boost performance for patients under 15, and we can say more about that. If we can move on to the next slide, the actual output of the model is a risk score, which is a number between 0 and 1. The way that and Antony will show this in the next few minutes, the way in which we actually present the risk score at the facility to a clinician when they're deciding whether or not when they're screening a patient, we don't show a number between 0 and 1, but rather we group the patient risk scores into 4 buckets or 4 classifications: highest risk, high risk, medium risk, and low risk. We can talk more about how we decided where to generate these cutoffs, but the driving factor behind these categorizations was the level of precision, the expected positivity rate. So for the highest risk, we were targeting we wanted the patients who we categorize as highest risk to achieve a certain positivity rate, high risk to have a lower positivity rate, medium risk to have a lower positivity rate yet. And then finally, low risk, we really want positivity rate in the lowest category as close to 0 as possible, so that we can have confidence in a decision to not test patients in that category. If we can move to the next slide, and here I'm going to hand over to Antony. This is just essentially summarizing what we've discussed thus far. The machine learning model building process, starting with the input data, the data sources from the National Data Warehouse, as well as using the GIS coordinates for each facility. We pulled in additional demographic, socioeconomic, and behavioral factors around the area in which patients are seeking care. We've gone through a couple iterations already of training a model, deploying a model, testing a model at sites in Homa Bay County, collecting feedback, and then enhancing the model to address areas in which the model was previously underperforming. So I'm going to stop here and hand over to Antony, who's going to talk about how he took the model that we developed and actually embedded it with KenyaEMR and made it available to decision makers in real time.
Thanks so much, Jonathan. I hope you can hear me.
Yes.
Okay. So model deployment, I'll call it plainly as the process of moving a machine learning model to a production environment. And while at that, I would just pose like 3 questions, like how is our environment? Where do we operate from? Our environment in Kenya is comprises of over 1,500 health facilities, majority of which don't have proper internet access. Then there is the next question about who the user is. Who do we target with this model? We target HIV testing service providers who are at the health facilities. They meet with clients, screen them and test them. And the next question is how we really want the users to interact with the model. The ideal one is a case that will provide near real-time predictions, more so in settings where facilities support point-of-care services. Now, just like any other step or stage in software development, of importance are 2 things, even in deployment. One is performance, and here I'm referring to the ability of your solution to actually provide predictions very quickly so that they can help inform providers real time. Then scalability. We have many facilities and we are looking to have a solution that we can easily deploy in all these facilities, having mentioned that majority of them have poor internet connectivity. Specific objectives relating to our context. With many facilities, majority not able to consistently connect to the internet, we were looking forward to an offline fast approach of deployment. We really also were looking at providing real-time responses to providers, easy deployment at facility level, and we were really looking at a solution that has none or very few dependencies on other systems. Then definitely consistency in predictions, and that is in comparison with, if we don't use the model, the original model, then whatever we needed to use should provide or give consistent predictions in line with the original model. And more importantly, uninterrupted or unchanged clinical workflow for the providers at the facility level. Next slide, please. So we basically explored, we researched, we explored, and we just got 2 options for us. One was to remotely host the model and have the EMR connect to it through API calls. And the next was to actually host the machine learning model locally in a facility. Now for option one, that is remotely hosting the model, so the setup is that you have a model hosted in, let's say, something similar to cloud hosting. Then you have the EMR systems at facility level. Then sending requests to the model and having the predictions back. I'm sure you can already tell how that process looks like. So basically data exchange is through API calls. So users at the facility capture data, key them into the system, that is the EMR system. They also need to key the same data to the central server and have the predictions back. So the predictions are to be pushed back to the EMR through API calls. Now, the advantage of this is that the process is really simplified because the model is just hosted in one server. The process of updating the model, retraining the model is very simple. But the main challenges is, one of our design objectives was near real-time response. I think with this approach, we'll really not have that, being that most facilities have poor connectivity. Again, there is slow response. Internet is involved. Whenever there is lag, you cannot be sure. Sorry. So because internet is involved, there is likely to be lag in actually getting responses from the hosted, from the server where the model is hosted. Next slide, please. Now, option two was to deploy the model in a health facility environment. And here we had two options. So the model that we use is developed in R. So R provides R Shiny which users can actually interact with. So the first option was to explore R Shiny, have it installed on premise, and have users also interact with this. There are different scenarios through which users can interact with this. The first one is actually having users key in data in the EMR and also in the R Shiny and have responses. That again will not be in line with our design considerations. The next option was to have the model distilled into if-then rules, which we could then use in the HTS forms. HTS is HIV testing services forms, and use those to actually help us have the predictions. The disadvantage of this is that we will just have up to two possibilities. Something is either true or false. But as you had seen from Jonathan's presentation, we have categories of risks, right from low risk to highest risk. So this again is not ideal in our use case. The third option in the offline category or basically the health facility environment category, is the use of PMML. That is Predictive Model Markup Language. This is a standard language for, representing machine learning models, and it's very portable, it's easy to use, it's well documented. And I've started talking about much about this because it was the preferred, approach that we explored. So next slide. This is so the right side of the left side of the slide shows the process of converting the model developed in R to a PMML file. This file is then bundled in the EMR, and the right side of the slide shows how that is used in the actual HIV testing services form. And like what you can see, there is high risk, and that is based, we've actually just got a prediction from the model. So the process is getting the model in R, it's converted to PMML. We have ready converters for that. And it's good to mention that it's not just limited to R language. Even models developed in other languages can actually be converted to PMML. These are then bundled. We then bundle these in the in KenyaEMR, and we have libraries that we have packages that we actually use, or that can be used to evaluate the PMML that is obtained after converting the original model. Now, this is what we now embed in the EMR. And in our use case, we still used API calls to just get predictions. The good thing is that it's part of the EMR. So when you look at deployment, if you deploy the EMR, then you also have the model with it. So the REST calls are still, the API calls are still local. So we are sure of real-time responses to providers. We are sure of, we are sure that whenever we want to deploy the model, we already have the EMR. So anywhere the EMR is, we are sure we'll be able to deploy the model. That is the process that we used in the EMR. And in the next slide, yes, so these are a few guiding principles for PMML. It's actually real time. If you look at how that works in the EMR, click on a button, you will have the response. So that is what we wanted, and that is what PMML integration supports. Also, the solution is now bundled with the EMR. It's part of the HTS module. So once the data science team led by Yoni updates the model, that same, the model is converted to PMML, the file is shared, and we update what is in the EMR. That simplifies deployment because it doesn't require any separate process for deployment or updating the model. Then I had talked about how our facilities are. The good thing with PMML is that it works both for offline and online environments. So if your setup has 100% connectivity, PMML works. If you have 0% connectivity, PMML works. And then again, there are ready libraries that aid the integration of PMML files in existing or even new applications. And the last point being that PMML is very standard, it's well documented, and I look at it as a way of actually providing interoperability of machine learning models across systems. Next slide. Okay, so like with any other process, it was important for us to be sure that whatever we get, whatever prediction we get, whatever risk score we get from the original model in R is the same risk score that we get with if we apply the same data, but using the PMML-based model. The good news is that the predictions were actually same. So if it's in the range of 0 to 1, so all that was same. And I think it's good just to note that even after converting the model to PMML, the same prediction that, I mean, the same result you get from the original model is the same one you will be getting from the PMML-based model. Next slide. Yeah, so for us in Kenya, we had our initial version of this work already deployed in the facilities. We've learned so much from the process, from interactions with the providers, and to enable us reduce even further the false negatives and even false negatives. We have introduced behavioral variables in the system. So the HTS screening form has been updated to screen people with a lot more behavioral variables, and this is with the hope that we will use these to improve on the predictions that are for the current model. Also, based on the predictions that we get, we aim to provide more referral services. For example, for those who screen negative. Yeah, and one last thing is just to extend ML services to other program areas. One area that we are currently considering is interruption in treatments and viral suppression. So this is for us a flagship assignment, and we hope to extend it to these other areas. Next slide, and I hope it should be the end. Thanks so much, and back to you.
Great, thank you.
Just
So at this time, if you have any questions, please enter them in the chat. I see there are a number of questions already waiting for us. Jonathan and Antony, would you like to go ahead and start answering those?
I'm happy to. I've been trying to answer a few of them in the text already. So
Excellent.
Some of them have moved to the answered category. I can maybe I can address Jana's question.
Okay.
Then Antony, maybe you can take the next one. So Jana asked, does each category have its own? Sorry, does each county have its own model? How often do you update the models, and how is that frequency determined? So we've actually had a bit of a evolution here. We started out looking. So the answer is we examine both county level models and national models. And we selected based on the performance metrics, based on the area under the precision recall curve. And what we found is actually that the national model performs best. It was particularly helpful for like I mentioned, for the under 15 patients, where on a county level, we just didn't have very many examples of positive cases. We also did things like trying to rebalance the data set with the under 15s using creating synthetic data, upsampling, downsampling. Ultimately, it was the national level model performed best overall and across the different sex disaggregates and age disaggregates. So we're using a national model, which also simplifies the process of maintaining the model, like you mentioned. So how often do we update the models, and how was that frequency determined? Right now, we're monitoring. We haven't settled in yet to a regular pattern. Right now, we're meeting with the CDC and different stakeholders from the government of Kenya on a regular basis, and essentially as issues or feedback comes in, we have a discussion about whether we should look at an issue where we retrain the model. Ultimately, what we're going to do is we're going to monitor performance. So we're going to monitor precision and recall in an automated manner, and we're going to set up a process so that when model performance starts to deviate from our expectations, we'll intervene and look at why and potentially retrain the model. So that's how we're looking at it, more than fixed periods of monitoring performance continuously and intervening when we see model performance start to slip.
Great, thanks. And there's one that I clicked on by accident, saying, looking at the ML model outcome, what are the criteria you use to classify the various outcomes?
The person who asked that question perhaps clarify the question. There was another question that I did answer in text, which should be in the answer category now, about how we actually determined the cutoffs, essentially, or how we created those categories of highest, high, medium, and low risk. So that I addressed in a different question, but I'm not sure if this is the same question.
I think it was the same person. So Mosere, if you have an additional question, please let us know. And then, are you seeing the question from Ramona Kiabagu? How did the quality of the data in the EMRs at facilities impact the accuracy of the predictions?
That's a really interesting question. I'm not exactly sure how to answer how the quality of the data impacted. What we did was, so first of all, credit to Antony and the KenyaEMR team. They've invested in infrastructure and processes over many years so that the quality of the data, I would also defer to Antony on this, but the quality of the data was overall quite good and was reported systematically. Still, there were many test results where we were missing input data, where we were missing some of those demographic variables that I mentioned. We had many examples where some of them weren't reported. And so what we did was we tried multiple avenues, and we selected the avenue that produced the best performance metrics. So what we did was we had we prepared one data set in which we accepted that the values were missing. Some of the classification models, the machine learning models that we discussed, can operate with missing data, particularly the XGBoost model. But then we also tried to impute the missing values. For that, we used two different methods of imputation. One we call it just a simple imputation, in which if it was a numeric variable, we took the average. If it was a categorical variable, we took the mode, the most common category that was observed. The second was we used something called MICE, which is an algorithm, multiple imputation for chained equations. I think it's what it stands for, which essentially for every missing value, it tries to predict the value based on all the other values. So if we're missing, you know, well, we weren't missing age very much. The missingness was kind of consolidated and, well, it was spread out across a few variables, but not so much age. But if a variable was missing, it tried to predict the variable based on the other variables that were present for that patient. So we proceeded with 3 different data sets, and every model that we trained in all 3 data sets, except for the ones with missing data where, you know, some of those models cannot work with missing data. And so that was actually another dimension. We tried different models, different hyperparameters, and for each we also use different data sets with missing data, or what we call our sparse data set, and then with multiple approaches to imputing missing data. And again, we just use the, you know, precision recall metrics to select which was performing best.
Great, thank you. Then we have a question: what were the predictor variables used? Performance on the minimum versus maximum input variables.
So the predictor variables were essentially what we discussed. So there were 12 to 15 predictor variables, demographic variables from the National Data Warehouse. And then we've done a couple different things, but with all the location, well, then we had a couple temporal variables. So because we also have the day in which the test was conducted. And so we derived some variables from the day. So we have some temporal variables, and then we have all the locational variables from demographic variables from Facebook and from Rollpop, from IHME, from United Nations and other sources. So we didn't I think I also kind of addressed this in one of the answers that I typed, but other than logistic regression, where we wanted to avoid having collinearity or a strong correlation between variables in the model, for the machine learning models, we didn't drop any variables. There were some variables that were essentially had no predictive power, or had very little predictive power, but none was actually adversely affecting the model, and so we didn't drop variables. I'm not sure if the question is also asking, did we do an assessment of, you know, adding variables one at a time or dropping variables one at a time to see how that affected performance? We didn't do that. What we did was we looked at traditional variable importance metrics. We then also generated 2 other types of analyses, which I didn't include in this presentation, but I'm happy to share. And we discussed this at length with our colleagues and our clients in Kenya and our colleagues in Kenya. We did something called, which is all about trying to understand the particular role, not just how. So what a variable importance will tell you is, of all the variables in your model, which are the variables that the model is relying on the most to make a prediction. It doesn't necessarily tell you how it affects the prediction. So it may tell you that age is a very important variable, but you have to unpack that, right? Age is important. How? Is it linearly, that as age goes up, the risk goes up? Is it not linear, which is probably not linear? And so there's 2 other analyses that we did. One is called LIME, which is linear. I'm forgetting what it stands for, but it's one is LIME and one is Shapley. One is a Shapley. We computed the Shapley values, or a Shap analysis. And so I'm happy to share the results of those analyses. But what those analyses are meant to do is, if those of you have heard sort of a terminology around a black box with machine learning, the objective is to try to open up the black box there and to understand not just which variables are important, but exactly how they are important, so that if a patient is in category moves, if the age increases by a certain amount, or if a patient were to switch from this category to that category, how would our prediction change? So sorry, hopefully that addressed some of what you were asking.
Great, thank you. I see there's a question on whether or not the model is free, open source, and accessible to all, or restricted users only.
So Antony, I don't know if you want to share anything about how it's currently, we've made all the code and all the data available to our counterparts. Certainly the data from the National Data Warehouse, I think, cannot be shared. All the open data sets can. We have our code in a repository on GitHub that right now is private. I I would have no objection to making the code open. I would just want to make sure that run that by our clients first. But in the meantime, if anyone is interested in accessing the code or learning more about the code, please do reach out. I'm always happy to discuss it and walk through it.
Great, thank you. Diwakar Mohan is asking, do you have plans for an overall impact evaluation?
Antony, do you want to take that one?
Yeah, so the process currently is that we still store or we still record the predictions that are provided by the model, as well as the testing outcome. And I think that can be used, one, to retrain the model, and also to carry out that evaluation as well. Did I get the question right?
I think so. Diwakar, if there's another aspect to that that you would like clarification on, please add a note in the Q&A. See, there's a few others. We're short on time. Jonathan, do you want to just quickly look through and see if there's maybe one more that you would like to answer?
Sure. I see Cleophas. I hope I'm pronouncing your name correctly. I don't have a great answer, but I really appreciate the question. The model is interesting. I'd like to know the perception of the healthcare staff. So I'm just chiming in to say, so do I. And as part of an impact evaluation, I think we'll want to look at first at how the facilities are actually using the model. And so we also addressed this a bit in some of the questions that we answered via type. But right now, we're not trying to steamroll the current screening process. We're trying to use machine learning to supplement it. Over time, we're gonna, through actual results of the model, but also, understanding the perception and the experience of healthcare staff as well as policymakers, we'll see how it evolves. It could be that, this stays as a second layer to try to catch people who are currently being screened out, or it could be that the machine learning model, supersedes the manual process. It's still an open question, and I think the perception of the healthcare staff will be a critical part of that. We'll proceed with the machine learning model and apply it as only to meet the level of comfort of all stakeholders involved.
Great, thank you. And I see there was a clarification on in the program impact question. It says, I meant the overall program impact and improved testing, treatment, and mortality, morbidity, not just functioning of the ML model. And I recognize that may be outside the scope of this work. But if Jonathan or Antony, if you know anything about that, you could share that.
Yeah, I wouldn't say that this particular project, this particular machine learning model is meant to, right? There are dependencies on other parts of the treatment cascade, right? Of other functions. So I think we're really limiting. We're focused on the actual volume of testing, positivity rates, and number of positive tests. Those are the metrics that we're really focused on. Then, in terms of linking from testing to treatment, and then the ability to retain patients in treatment and achieve, treatment success. That I think there's dependency on too many other things for us to say that those are direct objectives of our project. We're focused on the number of positive tests, the positivity rate, and the number of tests.
Okay, thank you. Okay, well, we are a couple of minutes past time. Thank you for staying a few minutes past, and thank you for sharing with us the information on the project. The slides and a recording of the webinar will be sent out to everyone who registered for the webinar. They will also be on the Data for Impact website on the resources page. And if you have any remaining burning questions, please feel free to reach out and we can see if we can assist. But thank you very much, Antony and Jonathan, for working with us today, and we hope everybody has a good rest of your day.
Thank you very much.
Thank you.